increase brand awareness and relevance, and enhance visibility and reputation across New York City and New York State. The Metro Plus Executive Committee considered and approved this on July 8th. Next slide, please. Our current contract is with Milton Samuels Advertising Agency, known as MSA, and was procured by RFP in 2016. It was recently extended in February of 21. The 6-month contract extension expires on August 12th. That contract extension was not to exceed $1.75 million, and the plan currently spends about $3.5 million each year with MSA. The H&H Board of Directors considered and approved that contract extension on January 28th earlier this year. MSA has delivered considerable results for us over the time of their contract. They helped with the launch of our ACA products, resulting in the largest number of new members in New York City at the launch. They helped with the launch of our EP plan, resulting in the largest number of new members also at launch. And they also helped us launch Metro Plus Gold to all city employees, resulting in double-digit growth year over year. In 2021, MSA earned the plan an online readership of about 408 million impressions, meaning that we reached those number of people through online media, print media, and television media. Next slide, please. Overall, according to Kantar Media and Nielsen Media's analytics in 2019, based on their reported figures, Metro Plus Health is at a significant competitive disadvantage, being outspent significantly by Emblem, Fidelis, and Health First, especially as it relates to television time. And based on the fact that Metro Plus Health's advertising numbers were grossly underreported, we feel it's safe to assume that even these numbers for our competitors are also underreported. These numbers represent an overall spend in print, radio, and digital with a substantial investment in TV. Next slide, please. Thank you. The scope of our RFP is developed based on our current agreement and includes the below areas: advertising campaigns, media buying, social digital marketing campaigns, television and radio marketing, art direction and creative production, public relations, and event planning. Metro Plus is seeking to award to multiple vendors to encompass the below categories: media buying, creative advertising and marketing, digital and social, and PR. Next slide, please. The measurements that we'll be using to determine contract success will be membership growth, lead generation, conversion rates, impressions, again, the number of individuals that are reaching through our digital, social, print, and television advertising, the reporting timeliness of that, and the increased brand awareness and reputation building for Metro Plus Health. Next slide, please. Procurement was handled as follows. On April 26th, an RFP was sent to approximately 53 vendors and posted publicly to the city record. On May 4th, we held a mandatory pre-proposer conference call. On May 25th, we received 21 proposals. On June 2nd, the evaluation committee met to review the proposals, and from June 22nd through June 24th, the vendors were all made presentations to that committee. The criteria that we used to judge those were their MWBE utilization plan waiver or certification, whether they had 3 years experience in media buying and or creative advertising and marketing, digital content, social media, and PR, preferably in New York City, in English, and many additional languages. The evaluation criteria was based on relevance and quality of their experience, their management and organizational capacity, their ability to adhere to the scope of work, performance guarantees and service level agreements, their cost, and their MWBE utilization plan or MWBE status. The evaluation committee consisted of the Chief Brand and External Relations Officer, the Chief Growth Officer, Chief of Staff and Strategic Partnerships, the Director of Communications, Senior Director of Customer Experience, Senior Director of Sales, our Head of Product, and our Lead Financial Analyst. Next slide, please. In terms of managing these relationships, it is pretty common today to have a consortium of vendors, which will allow every client to leverage specific subject matter expertise across a variety of categories. Our plan is to engage the vendors in those specific SMEs that they presented during their presentations. However, we've left ourselves the flexibility needed to access and activate their support in other categories where we need. Internally, our Chief Brand and External Relations Officer, our new Senior Director of Marketing and Communications, in partnership with our lead brand strategy vendor, will be responsible for coordinating, managing, and creating seamless collaboration and execution between the partners on these projects. Next slide, please. So our vendors that were selected are Prager Creative. Prager Creative has deep expertise in providing integrated marketing solutions within the public sector, branding, strategic positioning, traditional and digital advertising, and media stewardship. Prager will primarily be supporting MetroPlus Health with brand strategy, marketing and advertising campaign planning, and competitive media research. They have experience working with a broad range of healthcare clients with vastly different business objectives, specifically here in New York City. And they have substantial experience leading projects for industry leaders like us with fierce competition, such as Amex, GHI, and JPMorgan Chase. Next slide, please. Our second vendor is Bellwether Llc. Bellwether is an award-winning branding and marketing agency specializing in work with government and nonprofits. Bellwether will primarily support MetroPlus with branding and creative development, social media, video and digital content development, and analytics. Their expertise spans across many platforms, and they do have a media partner that can also help with media buying. They have experience working with New York City government agencies like the Office of the Mayor, the EDC, and the DEP. They also have a proprietary technology campaign reporting platform, which will give us access to real-time data and analytics, especially for our digital advertising. Our last choice is Milton Samuels Agency, who is our incumbent. Their current agency partner has been together for over 20 years. MSA will primarily provide us with multi-channel public relations strategies. They're a certified Google partner, providing all sorts of services, including mobile advertising and custom video, and they have experience working with a broad range of healthcare clients. Some of their clients include Northwell Health, NYU Medical Center, and MetroPlus Health. Next slide, please. Some of the key outcomes that we're looking to achieve is to develop an overarching MetroPlus brand marketing strategy, looking at specific strategies for lines of business, such as the Essential Plan and MetroPlus Gold. Much more deep research and insights, looking at our brand tracker, individual member demographics and psychographics, as well as consumer behaviors and competitive assessments. We also are looking for a fresh, bold, eye-catching creative moving forward, and a diversified marketing media mix so that we can reach specified audience targets. We also need improved analytics and digital measurement to track our return on investment and drive data-driven decision-making. And we want to fully leverage a peso marketing model so that we can really build 360 surround sound for MetroPlus. Next slide, please. As it relates to the MWBE status, each one of the firms either had MWBE status or all of them actually provided satisfactory 30% utilization plans for MWBE partners. Next slide, please. So we are seeking approval to enter into contract with Prager Creative, Bellwether Llc, and Milton Samuel Agency. Each agreement would be for 3 years with 2 one-year options to renew. The effective date would be August 13th, 2021. The cost during a 5-year lifetime would not exceed $20 million, $4 million per year. And all firms have MWBE status or a satisfactory 30% utilization plan. Thank you.
Great. Thank you. I'll go for questions. Dr. Katz.
No questions, please.
Dr. Calamia.
Yeah, just a sense of how are those metrics going to be developed? Are these vendors helping to do that, or how is that actually going to be
So
taking
there are
place?
some industry standards around developing the metrics for digital, print, and television advertising. But yes, every single one of our new partners will be assisting us in coming up with the KPIs that we're looking to track.
Dr. Morse,
No questions.
Dr. Harrison,
No questions.
Philip Wadley,
Questions?
Scott isn't here, Barbara.
I just have a couple of questions. I know that you all have been doing pretty good so far. But when we enter into contracts with these heavy duties, I'm only concerned about our client base and their effectiveness in marketing and communicating with our current client base and our communities specifically. And their ability to adapt to the volatility of anything like a COVID, 3 or 4 or whatever.
And one of the things that I think is going to be a great benefit to us is that these new partners have new tracking strategies that will allow us to actually look at real-time data, which is something that I'm not sure that we really currently have the ability to do. It'll really give us the chance to pivot some of our advertising strategies on a dime if we see that they're not actually meeting some of the impression and other metrics that we set out for them. So my hope is that we're going to be able to really look at each one of our campaigns and really along the way make any adjustments that are necessary so that they're highly effective.
Will they do focus groups in our target areas?
So some of the demographic outcomes in the key outcome slide is exactly what we need. I think we don't have enough information to make sure that we're targeting some of our audiences very specifically, and all of them will be helping with that. 2 of the 3 vendors are very rooted and grounded in research and insight.
Thank you.
Robert Nolan,
I have no questions.
Sally,
Terrific job, ladies.
Penioski.
I have a couple of questions. In the document, it shows that, for example, Prager will help with the branding strategy and Bellwether with branding. Are we expecting that we have to refresh the brand and the logo and how we present to the public? Is that part of this contract?
So that may in fact be part of the contract depending on some of the research that we actually do for some of our groups. We've done some focus groups. I actually inherited some focus reports where some of the outcomes are that there might be some brand confusion that we need to address. My hope is that we can dig into that a little bit more effectively, understand it much more deeply, and then make some decisions, but make those decisions based on data, not just based on what we think or what we feel.
That this contract will allow for that
Absolutely.
flexibility.
Yes, sir.
And my second question is that, it seems from what I understand, Prager and Bellwether will be more digital marketing and MSA will be more traditional marketing. Is that correct or that's?
So Prager and Bellwether will be primarily print, television, radio, and digital. They'll be handling much more of the marketing mix. MSA will primarily be supporting us with PR strategies, with earned media, which they've actually done a tremendous job of just over the last several months since I've been here. We've increased it significantly. So they're going to continue to do that work with us, but the new firms will actually be moving us forward in terms of creative, digital, print, television, radio, and non-traditional marketing like YouTube television, like Clubhouse audio, things that we are currently not using but have large audiences.
And that will include the bus stop and the subway? That will
Exactly.
be part of their strategy.
Absolutely, outdoor is definitely part of it.
Outdoors. Thank you.
Thank you. My questions have been asked. It was mostly about the metrics and the tracking, and it sounds like you guys have really focused on that and found vendors that can help with that. Because
Definitely, thank you for the feedback during the practice. It was very easy to prepare.
great, thank you very much. So I'll call for a motion to approve.
So moved.
Second.
Second.
All those in favor?
Aye.
Any opposed? Great, the motion carries. The next one is actually from my committee, authorizing the New York City Health and Hospitals Corporation, the system, to sign 2-year agreements with each of Approved Storage and Waste Handling, Inc., H, and Action Carting Environmental Services, Inc., Action, for waste management services with options to renew each agreement for 2 years, held exclusively by the system, subject to expenditure limits not to be exceeded on the ASWH agreement of $10,058,560 for the initial term, and 6902,000 for the action agreement during the initial term, and then 10,058,560 on the ASWH agreement during the renewal term, and 7,322,332 for the action agreement during the renewal term. This was presented to the Finance Committee on July 21st, 2021, and Paul, please take us through the presentation.
Thank you very much. Good afternoon. I'm Paul Albertson, the Vice President of Supply Chain Services, here to request approval to enter into contract for waste management services for the system. As background, the system entered into a 6-year contract with Stericycle in 2015, following a formal solicitation. The agreement included both the waste management and the carting disposal of waste with an all-inclusive fee. Waste management is comprised of several different waste streams, encompassing, for example, routine waste, construction debris, regulated medical waste, recyclables, and confidential documents. Not surprising, given the nature of the healthcare waste streams, there are several oversight and regulatory agencies and organizations with requirements and standards we must meet to ensure a safe environment for our patients, staff, and visitors. Next slide. There's also a significant amount of waste as well. For example, you see there's 44 million pounds of regular waste generated each year, 700,000 pounds of recycling material, 500,000 pounds of sharp, just as some examples. Each type of waste requires a unique container that permits us to standardize our education, training, and the appropriate management and assurance with our regulatory requirements for each of our waste streams. Given the broad nature of this service, every staff person in every facility uses one or more types of containers each day, and there are thousands and thousands of containers in daily use across the system. Next slide. Thank you. Given the depth and breadth of the service, there's a significant scope of service and related deliverables that our evaluation committee required, ranging from safety, compliance, standardization of services and training, technical expertise, full-time on-site management of services, and dashboard reports for tracking key metrics. On our next page here, an RFP for managing all or segments of the waste stream was posted in City Record. We asked vendors to provide proposals that reflected an integrated waste stream solution similar to our current program, or proposals for managing either the internal waste services or the external waste disposal. We had a robust evaluation committee composed of chief operating officers and representatives from post-acute care, Gotham, quality, facility, HR, and infection prevention. After several meetings, presentations, reference checks, and site visits, the recommendation was to move forward with 2 contracts as follows. Engage Approved Storage and Waste Handling, ASWH, for the management of internal waste services on a weight-based fee rather than a fixed fee, and engage Action Carting Environmental Services, Action, for the management of waste disposal and hauling based on a number of hauls versus a flat fee. ASWH works exclusively in the Northeast, manages the 8 Montefiore campuses as part of their portfolio, will be enhancing the management oversight, staff training and education, the reporting, and the engagement with our facility leaders. They possess the technical expertise and required licensure and will be assuring compliance with all of our regulatory and accrediting requirements and standards. While Action is our current waste hauler, in this new engagement, they will be contracting directly with health and hospitals to enhance service, our communication, our training and reporting. Action will be providing new enhanced containers at their cost for waste disposition with compacting capabilities. We believe we'll have enhanced services, better management, as well as a reduction in the amount of waste through transition to contracts, as well as through a non-fixed fee. Both vendors have provided 30% MWBE utilization plans. Detailed facility-specific transition plans will be provided by both vendors and will be reviewed with each of the facility staff in August for a coordinated changeover. I am requesting board approval to enter into contract with Approved Storage and Waste Handling, ASWH, for system waste management for 2 years with a 2-year renewal, exercisable solely by the system, effective October 1st, 2021, with a not to exceed of $20,117,120 million. And I'm also requesting board approval to enter into contract with Action Carding Environmental Services for system waste hauling and disposal for 2 years with a 2-year renewal exercisable also solely by the system, also effective the 1st of October, with a not to exceed of $14,224,332. Thank you. Happy to answer any questions.
Thank you. Why don't I open it up to the members for questions? Dr. Calamia?
You just related to, you mentioned about the educational component and all. One of the most difficult issues is distinguishing, those sharps, there's red bag, regular, and making sure there's not errors in that. And that's common to occur. I'm just wondering, do they play a role in helping with that process, identifying when there's been misappropriate use of any of those, or how do they participate?
Oh, great question, and absolutely, it's really a significant part of the role that we have from the technicians that work with the company, as well as from the management. They're responsible for helping to coordinate the education with us and actually performing it. This company is going to be able to provide it online so that we can make sure we reach a broader audience and being able to do it in huddles that across the system. The containers are marked differently for just that purpose. So there's the upfront, and then there's the look back as it relates to before the waste goes out the door, that there's a check there to help us too.
Thank you.
Dr. Morris?
Thank you again for the presentation. I was just curious about the criteria for choosing the contracts, and I'm wondering if climate impact is considered in the category around quality and substance of proposal, just since there's so much attention right now to how healthcare institutions contribute to climate change.
And yeah, again, a very important question, and I think that in part of our conversations with the vendors, that their ability of being able to autoclave and compacting is a big part of the plants that they are in fact improving and building here in our region. And our new vendor actually gave us a slide presentation on all that they're doing and how it's going to be managed. So it is a very important point for all of us.
Thank you. Any other questions? No. Great, so I'll call for a motion to approve.
So moved.
Second.
All those in favor?
Aye.
Any opposed? Motion carries. Thank you, Paul. The next resolution is number 4, authorizing the New York City Health and Hospitals Corporation, the system, to sign 11-month agreements with each of the 12 vendors listed in Annex A attached to this resolution, each a vendor and together the vendors, to perform COVID testing both in schools and in the community on an as-needed basis for an amount for all vendors not to exceed $250,480,410. This was presented to the Finance Committee on July 21st, 2021, and Chris Keeley is here to take us through the presentation.
Thank you. Good afternoon. Next slide. So, as everyone knows, New York City was hit exceptionally hard in the earliest waves of COVID. This contract is intended to provide significant amounts of community testing and in-school testing. You see here that testing in all New York City's public schools, there's about 14 or 1,500 schools in the public school system. That is to get out to them on a routine basis. Currently, that work is performed, as you see, by 4 vendors with an average monthly, or a range of monthly spend from $7 million to $34 million, with an average of $16 million per month under current contracts. Community testing provided by RRT, MedRite, and Premier Assist, with an average monthly spend of about $9 million. That is work that's done in the community, that is done with mobile units, that is done even at home testing to deploy teams out to close COVID contacts to test them in their homes. In May 2021, the CRC approved the release of a solicitation. Next slide, please. So here's some of the highlights of the work to date on the community testing side. So not in the schools, but on the streets, the community testing side. Since January, we've performed about 340,000 tests under this contract, including about 6% of those identified as positives, so about 21,000 New Yorkers who we identified through that. We've had deployments with at least 10,000 community partners, testing sites, and at-home visits. We have introduced accelerated contact tracing. So if someone gets tested at one of our mobile units on the sidewalk and they have a positive rapid result, we can do contact tracing either right there on site or telephonically in real time right after that positive result's identified. And we've also introduced at-home testing, as I said, for contacts of COVID positive New Yorkers. We can deploy a team out to test someone in their home, so they don't even need to leave their home to get tested, as well as routine testing at a variety of other locations, including supporting testing for unaccompanied youth that came up from the southern border earlier this year. So you see there, on an average day over the last handful of months, we've had about 50 units out on a day, and we've again performed about 340,000 tests. Next slide. Now shifting into some of the work within the schools. The DOE testing, we've performed 1.2 million tests in the schools since January. That's including at least 11,000 visits to the schools, numerous schools. You visit them multiple times, whether it's in the course of a month or over the period of time. We've supported the largest public school district in the country to be able to open in-person learning, including opening high schools in March, where you can see those numbers jump up from January, February in the 120, 150 range, growing to the 200,000 range, more towards the 250 to 300,000 range. That's largely a result of high schools coming online. And so we do visits to DOE elementary school, middle school, high school, as well as specialized GED schools, and the 99% of the tests, both on the school and the community side, have been returned within 48 hours. Next slide. On the MWBE performance, across these vendors that you see here, there's an aggregate spend of $44 million out of the entire 128 reported spend, 128 million reported spend. So 34% of the total spend has been with MWBEs, but that's been uneven, as it shows here. Some vendors performing more strongly, some vendors performing less strongly. January and May MWBE spend generally began more slowly. In June, 3 vendors exceeded a 30% from a monthly basis. 3 vendors exceeded the 30% target, as did the overall program total. In July, 3 vendors, under self-reported preliminary provisional numbers, 3 vendors are on track to meet the target. 2 others, VRL and Somos, have been meeting the target consistently. And the 6th vendor, Premier, makes progress. All figures here, again, just are provisional, especially the June and the July, I should say. Next slide. So from a contract development side of things, the scope is based on the current and anticipated need for in-school and community testing. We're looking at service level agreements of turnaround time rather than 48 hours, which had been the previous contract. Now we're looking at 24-hour turnaround. We're looking on the in-school side, a vendor to at least be able to deploy 15 teams per day. And on the community testing side, at least 8 teams per day. We can work with them to do either a per test or a per team structure. On the school side, it's entirely per test. Next slide. Rfp Criteria, we're looking for proven success in providing large-scale COVID-19 testing, ability to begin work and scale quickly, and MWBE certification or utilization plan. You see here the substantive criteria laid out, as well as the evaluation committee. Next slide. So we issued this RFP in May, 29 vendors applied, and we are seeking to contract with the top 12 vendors, those that's top scored in the top 12. Under this contract, work is entirely at the discretion on our side. There's no minimum requirements of work that needs to go to any given vendor. 5 of the vendors proposed to do both in-school and community testing, and 7 had originally proposed just school testing, but we've since asked each of those to also provide pricing to do community testing. That's so we can test them out in a community setting should we want This allows for cost savings with existing vendors and new testing capabilities. So right now, under our existing contracts, we don't have any vendors that provide, and we don't have a pricing structure that allows us to have them do saliva testing. Under this new contract, for example, now we'll be able to do saliva testing. So the not to exceed that we're requesting, as the chair said, is not to exceed $250.5 million, with about 151 million of that going for the in-school testing and the remainder on community testing. The selected vendors are on the right-hand side with the asterisks there, indicating the current vendors that we're seeking to re-engage with. Each of the current vendors we're working with, we are seeking to re-engage. Our 6 current partners, we're requesting to re-up with them, as well as add in 6 new partners. Next slide. From a management performance action plan, what we're looking to do is have monthly vendor level reporting to the board on the number of teams, number of tests, and turnaround time, as we saw in some of the earlier slides for both community and DOE, as well as the vendor self-reported MWBE. We'll be able to engage vendors monthly to review their operational performance, confirm ongoing contractual commitments, and review that MWBE spend is moving through the subcontractors as expected, and that the vendor continues to operate in good faith. If they fail to perform operationally, they have material shortfalls, or failure to participate in those ongoing reviews, it'll trigger a review of whether they're acting in good faith, and then we can act accordingly if we find that they're. Next slide. So we're seeking an 11-month contract, as I said, the not to exceed of about $250.5 million. We would only be spending funds agreed upon with OMB in advance and covered under the T2 MOU with OMB. And you see here from an MWBE perspective, utilization goals, each of them having agreed to at least 30%, along with subcontractors that each vendor has identified at least one of their subcontractors, a number of them more. So thank you again for this opportunity. Happy to answer any questions.
Thank you. I'll open it up to questions. Barbara?
Yeah, hi, good to hear from you again. I just have one growing concern, which is probably all of our growing concern with Delta. And if you can, I mean, your plan has been created and tweaked all along. Is there anything more we can hear from you regarding a real evolving crisis?
Sure.
How we will handle it?
So we tried to structure the proposal, and we tried to seek partners that would be able to provide capacity to meet the highest need we may anticipate, right? So if we go back to the intensity that we saw, let's say last December, January, February, hoping that the worst of the worst from last March and April and May are behind us, that if we were to look at from the original wave, if we were to look at the volumes from the second wave, this capacity, we would still be able to have dozens and dozens of community teams out in the field. We would be able to have dozens and dozens of teams out at the schools every day if the schools remain open in that scenario. We would have immense amount of capacity, and not only would it be there with these vendors, we're confident that we'll be able to ramp up quickly should that need arise. We already see those numbers increasing right now. We have immense amount of capacity that's out there under the current contract, and we're ready to expand however we need to. This contract does allow us to meet what we might be able to anticipate.
Anything about the teachers?
So on the teacher side, those conversations are still ongoing for schools opening back up. You know, the work is ongoing to continue to build out partnerships with the Department of Education, with the teachers union, and everyone else to make sure that as summer school wraps up in mid to late August and the school year comes back in mid to late September, that all of those, as you were asking about during the Finance Committee meeting, reaching out to all the different schools, being able to engage and educate parents and teachers about what this testing means. There's a robust plan in place that we'll be able to help partner with City Hall, with the Department of Education, with others, to make sure that we're getting that type of information out there.
All the best.
Bob?
Do you have a plan already for breaking down these vendors borough-wide? I'm sure that in a place like Brooklyn and Queens, which have double the population of the Bronx, that if you have 4 vendors in Brooklyn, you might have 2 in the Bronx. But I would think that you probably have something in place already. Can you talk about that?
Sure, and it's sort of different on the DOE in-school testing side than it is on the community testing side. On the DOE side, it is very much as you described, sort of a geographic turf-based approach. I'll send vendor A out so that they can get these 100 or 1,000 schools in a certain area, and that way they can maybe get to 2 or even 3 schools in a day because they're close by each other. With the community testing side, it's a little more thematic. So we'll have one vendor that might be able to do at-home testing, and they build out their logistics, their team, to be able to meet at-home testing. Another vendor that can build out mobile testing capacity, and they'll be able to have their units that can go out. So for each of the different sort of arms of the contract, we structure them slightly differently, but the schools very much is geographic, as you mentioned.
So from what I hear you saying, then any one of these vendors at one time or another can wind up in any one of the boroughs in the city, because they all have different responsibilities. They might not all wind up in every borough, but they're not restricted to these 2 in the Bronx and those 4 in Brooklyn and so on.
I think that's fair. We do want to
Okay.
keep it as flexible as possible.
Gotcha. Thank you
Absolutely.
very much.
Sally, did you?
Yeah, I just, when this all started many, many years ago, I was very apprehensive about the likelihood of success. I just thought the notion of people opening their door to you, identifying contacts, I just wasn't sure it was going to work. And entering communities where there's a high level of suspicion, and then interacting with so many different parties of interest. It's just a huge undertaking. So I just have to acknowledge the tremendous work that you've done. It really, yeah, congratulations to all of you on your success.
Thank you.
I actually thought at one point that your scope of work might decrease because you had done 1 million tests and you had the vans out there and maybe the numbers were going down, but I guess the times have shifted and you have the flexibility. So that was all, those are my comments.
Yeah. Thank you. Yeah, the hope here is certainly that we will only need a fraction of the capacity we're asking for here today.
Dr. Harris?
Yeah, thanks so much for that. I guess I have concerns with and it's less about the choice of who you're working with and more about the process, the DOE side with over 1,000 schools. How is the plans for the communication between the vendors and the schools and the parents and the kids to know in advance somebody might be there or this is going to happen? And how do you do that at that scale and do it successfully?
Yeah, absolutely. And we spoke about this a bit during the finance committee as well. That is certainly one of the biggest logistical hurdles of all of this. As I said in the finance committee, there are all of those logistical hurdles, and then on top of it, there's a 7 or an 8 or a 9-year-old getting tested without their parent next to them, right? And so making sure that the consents are lined up and all of that, right? It is immensely complicated for sure. And what we've been able to do since the beginning of the program is work through it with the Department of Education, keep the stakeholders engaged, like the unions, like the the parent associations, working with people to communicate out. We have been very stringent with the vendors in terms of if you're going to be late to a school, notify them. If, because we've got 50 teams out a day or 100 or 150 teams out of the day at times, somebody's going to get in a car accident, somebody's going to get stuck in traffic, so whatever it may be, that we have very, very tight sort of escalation procedures to notify those schools in advance when there's things like that happen. And we've also spoken in the finance committee about how do we hold some of the vendors accountable. If they're not adhering to that, if they are doing a no-show scenario, or if they're being disrespectful to a principal, or a student is complaining and we hear this isn't a one-off, this sounds like, then we start moving work away from them, right? So we do have that lever under this structure that no one's guaranteed work. We can just move it away from them practically overnight.
Dr. Morse?
Thanks again for the presentation. The assumptions under which you're projecting how much testing you're going to need have to be just mind-boggling. So thanks for trying to make it clean and clear for us. I just had 2 questions. The first question is just, my understanding is that there's no cost to the folks who were tested, right? Everything is completely free, but this is a big number. So I was just curious if you could talk a little more about the potential revenue streams for this. And then the second question is just around testing policy for vaccinated people, I assumed that the projections were kind of made under the assumption that testing for vaccinated people was not really going to be continued. And now, obviously, this one has changed everything. And so I was just curious if that dramatically shifts your projection, if you just will come back to the board with an update, or
Sure.
now that the CDC guidance has changed.
Sure, and we've had sort of every different program that we enter into under test and trace, we've been going in sort of assuming the worst, right? Assuming the highest volume, assuming that there will be logistical challenges we're not anticipating. And so in some ways, I'd say that we're sort of not even acknowledging that numbers may drop because of vaccination. We don't know when it's going to come out for the younger students. We don't know, everything yet about breakthrough cases, all these types of things. So we try to plan for the worst and hope for the best. So I think that you see here, these are very conservative numbers. This is assuming very, very high levels of testing. The hope is that vaccination and other, social measures will help to mitigate the need for that level of intense testing. But that is how we approach it. Oh, on the revenue side, and I'll ask the finance folks to correct me if I get this wrong. So all of this, from an immediate sense between health and hospitals and the city, everything, as it says here, is covered under the test and trace MOU with OMB. And then my understanding is that from there, all of this is intended to be submitted for federal reimbursement. I'm getting nods from finance.
Other questions from any members? No. I have one question, and also just great work. I know you guys stood this up really quickly, and everything's changing. Sorry, everything is changing. So, but on the numbers, what Dr. Morse was getting to, the estimates that you made, you think were based on when things were still bad. Is that right? Or because I think the average monthly for community testing for the new contract is $9 million a month, and I think what we said from the history was it was about $9 million a month. But and I thought things had been slowing down a little bit in terms of testing. So do you think that's enough? I don't want it to be more, but I'm just trying to hear the kids.
I do think it's enough. If we wanted to be further conservative, we could certainly make that argument. I do think that working with partners in finance, we have been very conservative on these numbers to try to mitigate the need to come back and ask for that. Part of the counterbalancing force with this is on the DOE side, as I said, everything is on a per test basis, right? We can know going in, we can assign a team, and we know how many tests they need to perform at that school that day. There is a minimum number that's required. On the community testing side, it doesn't work that way.
Right.
On the community testing side, we say, go to Worth and Lafayette and do your best. We'll send an outreach team out. We'll do some community organization partnership in advance. We're going to work with faith-based institutions and everything else to try to drive up volume, but we don't know how many people are going to show up. So in some
on
ways,
that, you're doing per team, or you're also doing per test?
So on the community testing side, right, that can happen where we do sort of the per team basis because we're deploying them into areas where we can't really anticipate the volume. And so the $9 million also sort of embeds in that the assumption that even if volume is really dropping, there's sort of a minimum to an extent that we might be going in with, and the $9 million there as a conservative ceiling, I think will get us where we need to go.
That's helpful, and because then the contrary would be true. If volume were higher, then because it's a per team, it's covered in the. So
That's right.
That makes a lot of sense in terms of the way that's structured. Okay, thank you. Any more questions? Oh, Sally?
Just a comment, if I can. I just want to note that there's so much cynicism about community groups really being able to perform, and the statistics and your work with them really proves that even under in such a demanding environment, you working correctly with them were able to have great results.
I couldn't agree more. So much of the success, especially on the community side, about partnering with those faith-based institutions. I mean, the schools, that's a different scenario. There are those institutional stakeholders that we need to engage, we always will. On the community side, the difference that those community partnerships make is immense. We set a target in mid to late January where we couldn't have a deployment without at least one community partner. By mid-February, I changed it with our team so that they needed at least 2 community partners for every single engagement. So we can't send a van somewhere unless we have at least two community partners. As we've gone through, unsurprisingly, you go back and you look at the numbers, those locations where we have 2 or 3 or 4 community partners, the numbers are better, the numbers are higher. And one of the other things that to me is one of the greatest benefits of working with a community partner is they're going to tell you exactly what you're messing up, right? They're going to tell you if the language access is off. They're going to tell you if you were 10 minutes late. And so they help hold us accountable at every step of the way. And so the program we were running in January, we're even more of a well-oiled machine here in June, July, August. Not perfect, but they really do help to speak directly to us and tell us how we can do better, how we can be more responsive to the community. And our team has really developed a culture among themselves to hear it, to internalize it and act on it. And that's one of the things I'm most proud of, the work the team's done.
Philip.
One last question. Does the DOE projection include the fact that we'll be going back 100% this fall, not just where we've been this spring?
It does, but we all, we discussed in the finance committee, I think it was, there are a lot of unknowns in there, right? Are we going to be on a monthly testing basis? Are we going to be on a biweekly, on a weekly testing basis? Are we going to be doing 10% of those consenting or 20% of the, there's a lot of those levers that are unknown. So in the same way, we sort of looked at this as a conservative estimate of if there's an intense level of, or not intense, frequent visits to the school, high thresholds for testing the proportions, and then thinking about most students or all students being in person, that is also baked into that $151 million assumption there.
Okay, thank you.
Great, thank you. So do I have a motion to approve the resolution?
So moved. Second.
Great. All those in favor?
Aye.
Opposed? Any abstentions? All right, we have a motion approved. Thank you very much.
Thank you.
Number 5, Peñamora.
Madam Chair, authorizing the New York City Health and Hospital Corporation, New York City Health and Hospital, to rename New York City Health and Hospital Coney Island Hospital, the hospital, as New York City Health and Hospital South Brooklyn Health, and designating the 11-story critical service structure building now under construction and the 16-tower building both at the hospital as the Ruth Bader Ginsburg Hospital, in honor of the late United States Supreme Court Justice Ruth Bader Ginsburg. This was presented to the Capital Committee on the 26th of July and was approved to be forwarded to the full board for consideration.
Thank you for the opportunity to present today. Coney Island Hospital has a catchment area of approximately 875,000 lives, which includes many diverse communities in South Brooklyn. We're incredibly proud of servicing Coney Island and its surrounding areas, but our patients come from many, many different areas of South Brooklyn, to the north of us, to the south of us, and also some areas in Staten Island and in the Rockaways as well. As we continue to build a brand new 11-story inpatient hospital, which is due to open in the summer of 22, we're also in developments of many projects around increasing our ambulatory care footprint and increasing access for our patients. All of this put together gives us a unique opportunity to rebrand and reposition the facility as a one-stop healthcare provider of choice for patients and residents of South Brooklyn and beyond. Next slide, please. A little bit of history. In October of 2012, Superstorm Sandy significantly damaged many buildings on our campus, and through much advocacy of many people in this room and many, many others as well, Coney Island Hospital received a $922.7 million FEMA grant to improve the campus infrastructure. That included several pieces. The biggest piece of the pie is going to the building of the new inpatient tower, which is designed to be at the 500-year flood level, which means that should there ever be another mega storm, we will be able to remain open and operational and be able to continue to serve our community. It also includes the building of a flood wall around the campus, which is at the 100-year floodplain. So our ambulatory care enterprise will also be able to continue should there be Another issue, hopefully there will not. The new building will open next summer, and the ambulatory care projects, some are already underway, and many more will start as our main building empties of inpatient services and those services move into the new building. We will be able to go back and renovate many areas in our existing building. To that end, we're working on a comprehensive master plan to rationalize the expanded ambulatory care footprint, as well as to address our needs for research, education, and staff support. That is a very important part of what we're planning to do in the future. Next slide, please. This is a little bit of what's going into the new building. Again, it's $920.7 million in FEMA grant. The new building will have an expanded emergency department, which is double the size of our current emergency department. State-of-the-art operating rooms, including robotic surgery. That's something that's never been offered on our campus before. And we will have several biplanes in that space, so we'll be able to offer a number of new services. A brand new endoscopy suite, labor and delivery, inpatient dialysis, and 80 private medical surgical beds. Now, just to give you an idea, the beds that we are moving to replace with these beds are in old 6-bedded rooms, which are now functioning as 4-bedded rooms. So we're going from 4-bedded rooms to single-bedded private rooms, and that is not something that is available in South Brooklyn. That is something that we can offer to our patients. The same thing with behavioral health. We're moving 60 behavioral health beds from a 1910 building into a brand new state-of-the-art facility on the 9th and 10th floor of this brand new building with floor-to-ceiling light, and probably the best views on the entire campus. We'll also have a brand new inpatient radiology, as well as a new interventional radiology suite, nuclear medicine and others, new clinical laboratory, and this is important, an elevated mechanical floor. Our mechanicals are actually going to be on the 5th and 6th floor of the new building, which means that they will be protected from the elements should something occur. Next slide, please. Because of all of these changes and because of the investments we're planning to make in ambulatory care, we really think that this is an opportunity to reposition the hospital in the community, and not to move away from our roots, to acknowledge them, but to really say that we're very proud of servicing Coney Island, but we're also proud of servicing the neighborhoods to the north of us, as well as other areas beyond. And so we're proposing to call the hospital New York City Health and Hospitals, South Brooklyn Health. We're also proposing to call the hospital the Inpatient Services, which would be the brand new building, as well as our inpatient tower, the Ruth Bader Ginsburg Hospital. That will be all of our inpatient services. And since our current main building, which is no longer will have inpatient services, nor will it be our main building, it will be our ambulatory care building for internal purposes and for wayfinding and elevator labeling. We're proposing to call that our Health and Wellness Institute. All of this will be in effect starting next year, in the summer of next year, when the new building opens. So this idea did not come lightly and did not come quickly. It involved quite a lot of interaction with our constituents and our staff. In the fall of 2020, when we began considering changing the name, we started several work groups, internal and external focus groups, to float the idea of changing the name. How would that be accepted? What is important to the community? What would make a difference? What would make the community want to use our services more? And several ideas came out of that. A lot of it was very much geography focused. The community is proud of being in Brooklyn, and they're proud of being South Brooklyn. And so, so that was actually very important. The other piece that was really important was this idea of health, as opposed to the idea of a hospital. So COVID very much taught us that folks don't want to go to the hospital to get their A1C checked. There's still some fear, especially in some of the newer immigrant communities. And so the idea of trying to send a message that we are, head to toe medicine, and that we're here for all your needs. We're not just a hospital, we're a hospital, an emergency room, outpatient services, community services, that we are here for your health, for your total health. That also was something that was very important. We have, since these ideas have come around, we've worked extensively with our community advisory board, labor union partners, elected officials at all levels. And here's the important part, selected staff members. So Coney Island, because of its geography, is very lucky to employ a lot of our own community members. And these folks have worked with us for many, many years. Some of them were born in Coney Island and now they work here and have spent their entire careers here. So we picked a number of people who have very deep roots in Coney Island, in the hospital, in the community, and we asked them what they thought, whether these ideas would be accepted, whether they would make sense to the community, whether they would help bring the community in. And we got very, very positive feedback across the board. Next slide, please. So this is a little bit more about why South Brooklyn Health. The idea of inclusivity is the most important piece here. We want to make sure that everybody knows, whether you've been here for 3 minutes or 3 generations, you know you're in South Brooklyn, you know you need healthcare, you know our doors are always open. So we really wanted to make sure that we were capturing as broad population as we possibly could, that we were there for the entire community. And I think I mentioned this already, healthcare is shifting from inpatient to ambulatory care. And so this idea of being health, South Brooklyn Health, allows us flexibility and allows us the ability to pivot as more and more services move to the ambulatory care setting. Next slide, please. I'm not sure I need to say why Ruth Bader Ginsburg, but so Ruth Bader Ginsburg was the late Ruth Bader Ginsburg was a U.S. Supreme Court Justice. She was the first Jewish woman and the second woman overall to serve on the court. She was the daughter of Jewish immigrants from Ukraine and Poland. We have very large communities from Ukraine and Poland in our surrounding area. She was born and raised in South Central Brooklyn. She went to Madison High School, which is not very far from where I grew up.
Amazing.
And she espoused truth, equality, and justice, and she really did give voice to the voiceless. That ultimately, and in fine-tune matches with the New York City Health and Hospital mission of serving everybody who walks through our door and helping all New Yorkers live their healthiest life. So next slide, please. This is a picture of our campus, just to give you a little bit more of an idea of how things will break down. The blue areas to the left, the area most to the left, that's our CSS, that's the new building that's going up, with the tower being right in the middle. Those services, as all our inpatient services, will be known as the Ruth Bader Ginsburg Hospital. The green building is going to be our ambulatory care building, and that will be known as the Health and Wellness Center. All of this will always be under the Health and Hospitals logo, so it'll be Health and Hospitals, South Brooklyn Health, and then there will be a sub-logo for the Ruth Bader Ginsburg Hospital. They will never appear separately. We are incredibly proud of being part of New York City Health and Hospitals, and so those images and those thoughts will always go together. Next slide, please. So this is a little bit of about the operating procedure. So we followed the guidelines of operating procedure 100-8 to get us here. We received support from the Ginsburg family to rename the inpatient hospital as the Ruth Bader Ginsburg Hospital. We worked with and obtained the support letters from the chairs of the Coney Island Community Advisory Board and the board at large. This has been presented to the Community Advisory Board in total. And as well as a letter from the president of the Coney Island Hospital, medical and dental staff, and this has been actually presented at one of our MEC meetings, medical executive committees. We obtained a support letter from our CEO, who's sitting right there. And we did bring this resolution to the Capital Committee a little bit earlier this week. So in addition, we also received the initial approval from the New York State Department of Health to rename the hospital campus and update the operating certificate to reflect the South Brooklyn Health name. So this is our resolution, and I'm happy to take any questions.
Thank you. I'll start.
Just a comment first. First of all, I've been on the board many years. This is one of my proudest moments, I must tell you. It's extraordinary. It is really a new page in my mind, Health and Hospitals. So I can't even describe how wonderful it is. Having grown up a few blocks from Madison High School, which also produced Chuck Schumer and Bernie Sanders and other people. But anyway, I think it's beyond exciting. I congratulate you on doing this. As I said, I think it's a new page. Naturally, also having been from Brooklyn, I just have to throw one little fly in the ointment, which is, South Brooklyn has always had a very traditional geographic area for people from Brooklyn. And I'm just wondering, I don't think it's a horrible thing to change the concept of South Brooklyn, but just to say Southern Brooklyn is typically what we think of as referring, because South Brooklyn, as you know, is it's the Red Hook and Windsor Terrace and so on. It's a very specific area of Brooklyn. So I just make that comment, but obviously otherwise this is just really great.
You're right, and we definitely floated this idea of South versus Southern, particularly with our staff members, as I mentioned, who've been and who are from the community, have been in the community many, many years. And frankly, we did not get a negative response. And in the spirit of inclusivity, that's kind of why we went with South Brooklyn, because it's the entire southern part of Brooklyn. It's folks to the north of us and folks to the south of us. And so we just want to acknowledge that our patients come from a very, very wide area, including some of the areas you just mentioned. And so that's why we went with South. But we did sort of float this idea that, would there be any concerns, negative feelings? And, University of staff were very excited. And so that's kind of why we went with this slightly shorter.
I guess you've just given yourself a lot more work in terms of justice and equity.
That's right. I'm proud to do that work.
Well, this is one of our historic milestones, obviously. And so, but seriously, women's rights and reproductive rights and such like that is her centerpiece. And so, just get ready.
I'm very proud to be the first female CEO of Coney Island Hospital and to have a mostly female leadership team.
Yeah. With a mini institute. Yeah. Okay.
More work to do. There's always more work.
Oh, it's all good though.
Sorry, Bob, Sally.
Yeah,
Sally first.
Sorry.
Yeah.
I just wanted to add my congratulations. You could have just taken the construction of the building and added it to your existing facility, and that would have been a good thing. And instead, you opted for radical transformation and re-envisioning all that you could be. And it was just brilliant. So congratulations.
Thank you. We're very, very proud of the work that our staff does every day. They do incredible work, and the campus saves many, many lives. Especially now that we're a PCI center, we just became a primary stroke center. We're bringing robotic surgery and many other services to our campus. That's not things that were done there before, but the people of our area deserve those services in their area. They shouldn't have to go half an hour in a car to go to another hospital. They should be able to stay right near home and get all the services that they need. That, we're a community hospital, we're proud of that. We're always going to be a community hospital, but save for really complex services, which are better done at our sister facilities, we want to be able to keep folks near their home.
Bob first, thank you. And Dr. Harrison.
Thank you very much, and congratulations for getting this far. As some of you may know, my wife is a Gravesend girl who I imported to the Bronx and through a special visa in 1876, and she's been complaining ever since. But while we were dating and we were first married, I said to her, "You're a Gravesend girl, and you're on your way, and Coney Island is over here, and right by Coney Island Hospital, you see the Bell Parkway. And on the other side of the Bell Parkway, right, is Brighton Beach. And on the other side of Brighton Beach down a little is Coney Island. So Susan, since your mother worked here as a volunteer and you worked here as a volunteer, why is Coney Island, which is over there, named after this hospital over here when it's really nowhere near Coney Island? And of course, she didn't know. She was, well, I work as a volunteer. So he's not giving me a hard time. But so the thing is, I know from somebody who spent a lot of time driving between Bay Ridge, far west, all the way over to Bergen Beach, because when we were in Brooklyn visiting our parents, everything had to be bought in Brooklyn, because Susan, where all the stores were in Brooklyn. She didn't trust the stores in the Bronx, even though I know this is public. But we've had a change in that. But I do know that whatever you wanted to get, you can get from Bay Ridge over to Flatbush Avenue where the shopping center was. So all that is just preamble to my one question I had to ask you. I see all of the letters of support that you received, and that's impressive. I also know from my own sense of things is that this area from Bay Ridge over to Bergen Beach and maybe a bit north into Midwood, where the great high school is, of course, take in at least 3 or 4 different community boards. I don't see community boards here, so I wonder, was there some outreach? I know that there are people on the Coney Island CAB who are also on community boards locally. So I wonder whether was the decision made not reach out to like 4 of them, or was there some initial outreach, and did you get any response from the local community boards?
So you're right, we do have representatives of, from the community boards on our CAB, and so we reached out to them. It's a little bit of the situation, we wanted to talk about it broadly enough to understand whether the communities would be supportive, but we didn't want to let the whole cat out of the bag, so that now we could have a reveal and begin our very extensive marketing efforts that we're going to take on over the next year. So we really spoke to the folks who are on our CAB, who represent all of those community boards, to make sure that they didn't feel that there was concern. We are now going to, now that it's kind of public, we're going to very actively work with those community boards, because frankly, we're very proud of the area where we've been, and Coney Island Hospital is a very historic name. It's been around a long time. So in no way do we want to minimize that. We want to make sure that everybody who used our hospital still feels comfortable using our hospital. That's very, very important. We just want to make sure that, everybody else and all of the new communities that are entering these areas also feel comfortable using our hospital. And there are some communities that use us very heavily and others that don't use us at all. So this is an opportunity, but we have engaged them through our CAB members, and they've gone out and they've talked to whoever they've talked to, and I've yet to hear one negative thing coming back from our CAB. They were universally very, very supportive.
Thank you very much, and congratulations.
Dr. Harris.
Yeah, thanks again for the presentation. And I have a sideways question, just because you talked about what's going to be in the new building where you mentioned 60 psychiatric beds. Is that any different from your current number of psychiatric beds?
So today we have 64. We will have 60 with a potential room for 1 more. So it's not significantly different. We have also reduced our length of stay on the psychiatric units very significantly. So we feel very strongly that this is enough to service our community. I will say that on the ambulatory care side, we have a brand new behavioral health ambulatory suite that is actually under construction right above my office, literally right above my office. And so we're going to be able to offer very, very extensive ambulatory care services on campus.
I wanted to speak for a moment in favor of this and thank you, Svetlana, and thank behind you the 2 great women who have supported your efforts. Christine on the Capitol Way and Deb on the in terms of Community Advisory Board. And I also want to add to Bob Nolan's history, because this is the area that I grew up. I grew up about 1.5 miles north of Coney Island Hospital. My great-great-grandmother, not my mother, not my grandmother, but my great-grandmother, great-great-great-grandmother got her care in the 1930s at Coney Island Hospital. My parents got their care, my grandparents, my siblings, all of us growing up. This was our community hospital. To Vince, what you're saying, we would have never said we were from Southern Brooklyn. We would have said we were from South Brooklyn. So it's in fact, when this came up, this was the first time I'd ever heard of the idea that another neighborhood saw themselves as South Brooklyn. That's okay. We all learn stuff.
Change,
Right,
everyone's orientation.
but I had never.
Look at it.
I grew
But
up in
South Brooklyn
South
really
Brooklyn,
is
meaning
Mark
Sheepshead Bay in South Brooklyn. What I wanted to add to Bob, just to show how much we're moving forward, as Bob was alluding to, Coney Island Hospital is not in Coney Island. It's on Coney Island Avenue, but
It's
not
not on
on
Coney Island Avenue.
It's not even Coney Island. It's Ocean Parkway Avenue. It's close to Coney Island. Sorry. Even sorry. So it's not in Coney Island. And Coney Island isn't an island. Coney Island is a barrier island. Coney stands for rabbits, presumably because before it was filled in, the water, it must have allowed for the reproduction of a lot of rabbits because there must have been no predator because it was an island. Right. So here we are, we have our precious resource, which is named after Rabbit Island, which is not an island and not where the hospital is, and has absolutely nothing to do with health, and is, now we're moving to a name that represents what it is, where it is, what it does, that it does health, and that it honors someone from our neighborhood who so many of us admire for so many reasons. And so, I think this is an amazing, amazing moment, and we're all looking forward. I'll mention one other feature of the current Coney Island Hospital. It's our only hospital where we still have hall bathrooms, just to show the progress that we're making. That currently, can you imagine that, right? I mean, right? So you're in a hospital. We're trying to prevent infectious diseases, and a bunch of people are sharing a hall bathroom, right? So that's how much progress we're making with the opening of this to go to single rooms. I think the majority health people believe all hospitals should now be built with single rooms because it's impossible to do infection control. And we saw that, of course, intensely under COVID, especially in the early part where we didn't have enough testing capacity. So we often did not know. We had to make best assumptions about who had COVID and who didn't have COVID because we quickly ran out of space, right? And so we were using large open areas. So I think the future of hospitals is to say people should have private rooms, and that also allows relatives to stay. I would never allow a relative of mine to stay alone in any hospital if I could, prevent it. But of course, if you're in a 4-person room and you're a son and there are 3 women who are not your mother, how do you stay with your mother, right? It becomes quite an issue, right? So private rooms allow you to have a relative, a loving friend stay with you, which I think promotes healing and safety. So for all those reasons, I think this is a great thing, and I thank you for it.
Any other comments, questions?
Just one comment,
yes.
just to make sure that this name, should it be approved, would become effective in the summer of 2022 when our new building opens. So it will all be a package that goes together.
And we're all really looking forward to being there at the opening.
We all.
Well, I think everybody has said all of the same things that I would have said. It's an amazing opportunity, and I did wear my collar today, but it's a dissent collar, so I'm keeping it covered because I do not dissent. And this is terrific. So can I have a motion?
So moved.
All right. All those in favor?
Aye.
Any opposed? Motion is carried. Congratulations.
Thank you very much.
Great job.
Great job.
Good afternoon, not an easy one to follow.
The system to secure a 5-year revocable license agreement with the Volunteer Heart Resuscitation Unit and Ambulance Corporation of Staten Island. The licenses of an ambulance service and 500 square feet of space for parking on the campus of New York City Health and Hospital Seaview Nursing and Rehabilitation Center, the facility, at an occupancy fee of $7,951 per year to be escalated annually by 2.5% for a 5-year total of $41,793. This was presented to the Capital Committee on July 26th, and it was approved for consideration by the board.
Thank you. First off, before I begin, I want to just quickly thank the board and health and hospital leadership for all the support during the pandemic. The post-acute care service line was certainly faced with its share of challenges, but the support was truly appreciated, and the ongoing support is very much appreciated. So thank you very much. On the screen here, you can see the Seaview campus. Currently, there's a multitude of occupants on the campus. As many of you who have been to the campus can quickly see, there are buildings that are the condition is poor, and we are working diligently to revitalize the campus, which deserves it. But when we have an opportunity to align ourselves with an occupant that buys into the mission and values of Seaview as a facility and as a community pillar, we want to take advantage of that. Currently, Volunteer Heart, thank you, occupies the top floor in the surgical pavilion. A little background about Volunteer Heart. They are a volunteer resuscitation unit. They're known as Valley Heart. They've been on Staten Island since the mid-90s, where they have been calling Seaview, making Seaview their home. They are comprised of EMTs, and they are operating essentially 24/7 to service the Staten Island community and provide a service all through volunteer work. They're really doing amazing things. They're a local not-for-profit, and they pound the pavement every day to make the lives of those on Staten Island that much better and safer. Next slide, please. As I mentioned, currently they are occupying the top floor of what is called the surgical pavilion. As I mentioned, the Seaview campus, which once was a tuberculosis sanitarium, is full of old buildings that are just sitting idle. They, meaning Valley Heart, have done an amazing job in revitalizing their space. In 2014, they moved into the surgical pavilion, which is where surgeries were once performed. They invested $300,000 in renovations, including the roof, which is obviously a very important piece of the puzzle. They, the bottom half of the pavilion, I should add, is the Seaview Museum, which houses a lot of the artifacts from the tuberculosis sanitarium.
Good afternoon, Christine Flaherty, Senior Vice President of OFD. So I'm just going to go through the terms of this agreement, this license agreement, which is essentially a not a market license agreement. This is really to cover some potential costs associated with utilities, etc. This nonprofit is really, as Matt already mentioned, really maintaining the space. I walked the space myself. Without that roof repair, this building would be continuing to have additional structural damage. And so it's important to note the benefit that they're providing to Seaview, which has tremendous potential to further activate for the community of Staten Island. So this is going to be a annual rate of $7,951, escalated at 2.5% per year, which is our standard escalation rate. It would be a 5-year term, and the occupancy square footage, including parking, is listed here. The licensee also will obviously take care of their own housekeeping and interior maintenance of their space, which is helpful for us. And I would want to note another feature of this organization. If you notice on the map, FDNY is also on this campus, and this organization really are people that work every day doing their day job, and then at night, or on a different shift, I should say, they're really spending time with potential EMTs and bringing them up the career ladder. So not only are they providing volunteer services for the community, they're also giving back to the next generation of EMTs for Staten Island and other boroughs. I mean, when I met the volunteer president, he was somebody who worked in Brooklyn for FDNY, but he did this on, he did this volunteer work out of the goodness of his heart. So it's clear that this organization's mission, the mission they serve, is definitely a benefit to both Seaview and Staten Island. So this is in terms of the resolution. We're happy to take any questions.
I will open it up for questions.
Just a question, really, just a comment. I mean, I think they're well known on Staten Island. They've done a tremendous amount of work, on behalf of community events and so on. So I just want to say bravo that they are on our campus.
Yeah, I think that's a great point, Dr. Cullum. They're always there when we need them. They're there for community events. They're there to educate, train. They're doing great work.
Ms. Lowe?
Yeah, is there any opportunity for young adults to possibly come into the fold with that group?
Yeah, so if you go to their website, you can actually see volunteer now. So their volunteer number is between 50 and 60. It fluctuates, I think, kind of dynamically, but they're absolutely open to getting volunteers, and it's really just a matter of reaching out. And so I think that's one of the things we really like to see.
Hopefully with successful employment down the road.
Yes.
That would be ideal. I have to look after my kids.
Any other questions or comments?
No spirit.
Great. I call for a motion to approve the resolution.
Second.
All those in favor?
Aye.
Opposed? Great, the motion is carried. Thank you very much.
Thank you.
Mr. Peñamore, another.
Thank you, Madam Chair. We are now in item number 7, authorizing the New York City Health and Hospital Corporation, the system, to sign a 13-month lease extension with Hazel Blue Plaza LLC, the landlord, for the use of approximately 2,000 square feet of ground floor space at 49-02 Queens Boulevard, Queens, to operate a supplemental food program for women, infants, and children, the WIC program, managed by New York City Health and Hospital Bellevue Hospital Center, Bellevue, at a base rent of $92,168 per year, or $46.08 per square foot, for a total of $99,848.58 for the 13-month extension, provided the system will hold an option to extend for an additional 5 years with a rent for the 13-month extension and 5-year option term together, totaling $596,425.50. This was presented at the Capital Committee on July 26th, and it was approved for consideration by the board.
Thank you. Good afternoon. My name is Marcia Peters. I'm the Chief Operating Officer at Bellevue Hospital, and I'm happy to once again follow in the footsteps of Ruth Bader Ginsburg as an attorney and also living in Brooklyn, my adopted home for over 35 years. I'm here with Helen Ho, the director of our WIC program. Good afternoon. The system operates over 17 WIC sites located in a combination of system control spaces and rented and leased spaces. The WIC program provides services for pregnant and breastfeeding and postpartum women, infants and children less than 5 years of age, who are determined to be of nutritional risk. The WIC program also provides services which includes monitoring of children's growth rates, nutrition education, breastfeeding support, and high-risk counseling. Bellevue Hospital operates 3 sites. Canal Street, which serves over 1,000 participants. Bellevue Hospital, which serves about 2,700. And in Queens. The Queens sites was approved by the New York State Department of Health because in 2009, the state determined that over 25% of our participants were coming in from Queens. And they believed that we should open a site that would serve that population. As you may know, Bellevue is not a traditional community type hospital. Bellevue serves patients throughout the 5 boroughs and including Long Island and Westchester. Next slide. We have operated this program since 2011, and during Superstorm Sandy in 2012, we were able to deploy staff to this Queen site and also redirect patients who could not come into Bellevue to get this much needed service. The program occupies 2,000 square feet of the ground floor of this rented space. And as you can see, we have determined that we can do better with the branding and signage. So once we get this extended lease, we intend to do so.
This shows you the location of the WIC Center relative to both Elmhurst Hospital, which also has patients being served out of the center. So that's a note that we want to share. Next slide. The lease terms here involve a base rent at $46.08, which is 2.5% increase from the current rent. We are doing some things to line this rental agreement and this resolution up with the timing of the New York State Department of Health grant, so that in the future we're looking at the resolutions kind of with the same timing. And so with that in mind, we have a 13-year extension as the main resolution, and then the option for a 5-year, so as to reduce the amounts of time we're coming to the board for these types of resolutions. We would look to hold that 5-year option for renewal and still have all of the same continuous terms in our lease agreements. This is within the fair market value range that's provided in the resolution, and the option term would commence October 1 for the 5-year of 2022. Next slide. This shows you the rent schedule for the 13-month extension as well as for the option 5-year term, covering the 13-month at $99,000 and change, the 5-year term for $496,000 and change, all with escalation rates of 2.5%. And the total authorization request for the 6-year 1 month, should the option be extended, would be the $596,425.50. And finally, we conclude with the resolution. We're happy to take any questions. Thank you.
Thank you. Any questions from the members? No? Great. Call for a motion to approve. All those in favor?
Aye.
Opposed? The motion is approved. Thank you.
Item number 8.
Yes.
Authorizing the New York City Health and Hospital Corporation, New York City Health and Hospital, to execute a customer installation commitment, CIC, with New York City Department of Citywide Administrative Services, DCAS, and New York Power Authority, NYPA, for an amount not to exceed $35,469,158.74, including a 7.5% contingency of $2,022,938 for the planning, design, procurement, construction management, and project management services necessary for the installation of a 4-megawatt cogeneration system, CHP, the project, at New York City Health and Hospital Bellevue, and this was presented to the Capital Committee on the 26th of July and was approved for consideration by the full board.
Good afternoon, Christine Flaherty, Senior Vice President, OFD, and Oscar Gonzalez, our AVP of Capital Development. H&H and Health and the city, we really remain committed to energy reduction and carbon reduction, and looking at that across the city. We're working within the framework of both Local Law 84, which really introduced energy benchmarking, energy audits, and energy retrofits into building requirements, as well as Local Law 97, which was more recently introduced, which really doubled down on major goals for carbon reduction for the city and all buildings across the city. H&H is part of the citywide goal for city-owned buildings, which has tremendous carbon reduction goals. And since 2007, I'm proud to say our team has reduced our carbon emissions by 33% as of fiscal year 2020. We're really excited about getting our calculations for 2021. Since 2017, we've been working on this project, pursuing and finding pathways for a combined heat and power project at Bellevue Hospital. Our energy goals are really important pillars as we look at energy and carbon reduction opportunities. So clearly we want to reduce our energy power generation, how much energy we're using. We also want to make sure we're reducing our greenhouse gases in all of our projects. And we're looking at resiliency as well, ensuring that we're creating scenarios of redundancy that are so critical in a healthcare structure. And finally, these projects do bear financial benefits of cost savings on an annual basis. Currently, Con Ed serves Bellwether Hospital both with electricity and steam. This serves the 2.3 million square feet of inpatient ambulatory pavilion at Bellevue. And just to quantify the amount of use, our utility bill is a $12+ million bill for Bellevue. That includes over 500,000 of what's called MMBTUs of energy, which is a measurement of energy, and 589,000 kilowatts of electricity. Just to give you a sense of how much of that amount of the MMBTUs is tied to the steam that we're getting out of the Con Ed plant, 299,000 plus MMBTUs come from the Con Ed steam. This project did have to go through a number of reiterations as we looked at the complex regulatory environment associated with on-site generation and carbon reduction. And we required a sign-off for this project by the Public Service Commission to get the on-site generation approved and ensure that we did not come under penalties by standby tariffs that are sometimes in place. Next slide. So the project goals here is that we're pursuing a resiliency and energy project aiming to reduce our utilization of the Con Ed power and steam services. We're doing this by installing 400 megawatts of combined heat and power system on our campus, which will generate continuous on-site electricity and thermal energy. This will supplement what we receive from Con Ed steam and power and provide us that resilient backup in the event of sustained grid disruption. Next slide. This shows you an overview of where the project will actually be constructed. The project would be located adjacent to what's called the Link building, and it would be a small plant, including the necessary equipment, and that plant is going to also recover the steam through thermal energy that makes it even more efficient by recycling that hot water for heating and cooling. This will also involve improving our electric feeders that are located in the electric tie-in placement. And what we've shown on this also is the green line shows you where our future community flood wall project, which we're really excited about starting design in this coming fiscal year. So that gives you the sense of where everything's located. Next slide. This gives you a sense of the features of the plant. It's an elevated structure. As you can see, it has a quiet operation. The equipment is easily accessible, and it's really a number of engines that are operating in a safe environment. We've established this project to be fully resilient, recognizing we anticipated being completed in advance of the community flood wall, so that once it's up and running, it will be within, constructed above the 500-year floodplain, which adds the backup to power to the facility in the event of a grid disruption. Next slides. So this gives you some metrics associated with those early goals I talked about earlier. The energy efficiency, how much energy are we reducing from our current utilization? We're looking at over 1,600,000 MMBTUs and 32 million kilowatts of electricity. We're looking to reduce our greenhouse gas emissions occurs through this project, and we're bringing 4 megawatts of power that provides approximately 40% of our peak power demand and 85% of our off-peak demand. So you can see this is a sizable portion of power coming to this facility, which will allow us to operate as a microgrid. From a savings perspective, we anticipate saving $3.7 million annually from this project, which warrants a little over a 10-year simple payback. Next slide. This just shows you in layman's terms what we're saving annually. So over 400,000 miles of car driving a year, 35 vehicles off the road, or you could look at it as 30 homes. So trying to bring the terms of kilowatts and MMBTUs into a way that everybody can relate. So we thought this was an important slide to show the savings for carbon. Next slide. So we're looking to deliver this project through our partnership with the New York Power Authority through the Encore 3 agreement that was negotiated earlier on. Next slide. The funding for this project is a combination of DCAS 1 NYC capital, city bond funding as well as, so this shows you our sources of funding. There's an interest contingency, which truly ties to prompt payment and reimbursement, and we're working closely with finance. This is really just a contingency. We do not anticipate needing to use that, but this would be the total project cost should that be exercised. Next slide. This shows you a breakdown of the total project by line item. Most notably, the largest portion of work here is the construction and the construction contingency itself, estimated at approximately $28 million. And this shows you all of the budget breakdown for that total project authorization that we're requesting today. Next slide. NEPA is our partner of delivering this work. They are deploying this through design build delivery, and they have gone through the procurement process and have identified Dynamic US Inc. as the design build contractor for this project, whose services were acquired through competitive bidding. In January of 2020, they selected Guth Kunzo, who's doing limited CM services for this project, and we're carefully looking at the capacity of this organization to ensure that they're covering this project appropriately. NIPA has a very active MWBE program, and they also recognize service-disabled veteran-owned businesses. Next slide. The next slide shows you the MWBE utilization plan for this project. 44% MWBE and 8% service-disabled veteran-owned business. So this is an incredibly diverse team that the design builder has identified to execute this project, which we're excited about. Next slide. And then finally, we'll wrap it up with the resolution. We're happy to take any questions. Thank you.
Any questions or comments? Sally?
I'm just out of curiosity. How long did this project take to go from concept to where it comes today? And how long is it going to take to construct?
So it took about 3 to 4 years to come here today. So this was pretty complex because of the, as one of the bullets noted, you have to make sure you have sign-offs and look closely at the standby tariff concerns associated with some of the complexities generation.
And the construction?
24 months.
Thank you.
Any other questions? Great. I think it's a great project. So can we have a motion to approve?
So moved.
All those in favor?
Aye.
Opposed? The motion is approved.
Thank you.
Thank you. Dr. Calamia for our last and final resolution.
Thank you. Authorizing New York City Health and Hospitals Corporation, the system, to negotiate and execute an extension of its affiliation agreement with the State University of New York Health Sciences Center at Brooklyn, also known as Downstate Health Sciences University, SUNY, for services at NYC Health and Hospitals, Kings County, KCHC, and New York City Health and Hospitals, Coney Island, CIH. Although I have to say RBG would sound much better, but all right, we'll just bypass that.
I love it.
It just has a great ring to it. Through June 30th, 2023, for cost of $22,435,966, prior to a 10% contingency for total not to exceed of $24,679,563. This was presented directly to the board because of the time limitations related to this.
Dr. Calamia. I'm Dr. Michelle Allen, the System Chief Medical Officer, and because it takes a team to get these affiliation agreements done, I'm here with General Counsel Andy Cohen. I'm also here with James Cassidy from Finance, and we actually had Deb Brown, the woman from Regulatory, just to acknowledge the team that has been working on this. But as you see with this slide here, we entered our contract or agreement with SUNY back in July 2016. It was a 4-year agreement. The board approved a 2-year extension in 2019, and we're here today to ask for a 1-month extension. Due to the time required to simultaneously address our 3 larger affiliate negotiations,
we've not had the opportunity to devote the appropriate time and consideration required for the SUNY negotiations. Thus, we're asking for an extension of the current agreement to allow a thoughtful and fulsome negotiation and partnership. Because SUNY's collective bargaining agreement with their professions unit, UUP, their union, that collective bargaining agreement requires SUNY to provide its employees with a 1 year's notice of termination of employment. And unless we agree to an extension, SUNY will have to give notice of termination at about this time to the approximately 85 physicians who provide clinical services at either Kings County or Coney Island. The extension is requested so that services can continue without distribution, without disruption, and allow time for the parties to negotiate a new, longer-term contract. I'm going to turn it over to James.
Dr. Allen, so we go back to slide 3 for just a second. What we're showing here is the year-over-year spending SUNY contract. So we can see that it increased from fiscal year 16 at about $14 million to fiscal year 20, where it went to about $21 million. But since that point, it's relatively stabilized between the period fiscal year 16 through 20. We did ask for some additional service we provide, and especially hard services for other affiliates to provide, that we were able to have them do that for us, but we've since essentially cut the contract flat. You can see in fiscal year 21 and fiscal year 22, the year-over-year increases are quite small. We can go to the next slide. So what we're asking for here is for fiscal year 23, so from July 1 of 2022 through June 30th of 2023, we're asking for $22,435,906, which is a small increase from the current fiscal year 22 initial budget. We're really just putting in collective bargaining agreements as well as other small inflators that are natural for SUNY as well as other affiliates before we have a 10% contingency. As with our existing extensions that we have with our other affiliates of Mount Sinai, NYU, and PAGNY, we had this 10% contingency for this period. The other contracts also had a 5% COVID contingency, but because those were for fiscal year 22 and year 23, we are hoping and felt that the 5% COVID contingency is not necessary. As Dr. Allen mentioned, we're doing this for fiscal 23 because of the 1 year notice that's required, and since we do have our current arrangement for fiscal 22.
So the extension allows for the uninterrupted provision of the same services at Kings County, where we have approximately 47 FTEs, notably in the emergency medicine department, psychiatry, and radiology. The extension also allows for the uninterrupted provision of surgical services at Coney Island, where we have approximately 2.8 FTEs. The affiliate will continue to comply with state regulations, national accreditation standards, and facility bylaws, including the appropriate resident program supervision. Go to that slide there. So the base for Coney Island is $1.1 million. The 10% contingency is $113,000, with a total not to exceed of $1.2 million. Kings County, the base is $21.3 million, and a 10% contingency of $2,130,091, with a not to exceed of $23,430,997, which brings us to a total of $24,679,563. The proposed payment to the affiliate is based on costs. The cost reported assumes no material change in patient volume or services provided, and no additional impact from managed care programs or other third-party developments. The last slide is the resolution and our asks. Thank you very much.
Thank you. Any questions? Sally?
Very quickly, 2 questions. Was the increase from 13 million to 20 million in 2016 to 20 million in 2018 just an expansion of services provided?
Yes, that's right. Yes. Because it's a cost-based contracting, it's the actual services that are provided, so the number of staff decreased.
And when you look at the different variable costs compared to the affiliate contracts we originally approved, are they in line? Are they in keeping?
Yes, definitely, the SUNY contract has remained, I mean, they all have, the SUNY contract specifically has remained very close with the budget, so we've had versus the actual fee. Extremely small recasts are necessary.
Thank you.
Any other comments or questions? So could I propose a motion to approve? All those in favor?
Aye.
Opposed? Motion is approved. Thank you. So we now will have Dr. Cass's report.
Given,
No, you aren't ready to leave. We're done with our
I'm pretty
resolution.
sure they were all ready to leave.
I'm not leaving.
I think they were ready to leave, and I don't want to hold,
No.
but it's people can read the report. I do want to spend a minute talking about the impact of the vaccine or test requirements for our workforce, because that goes into effect on Monday, and it's huge. So we talked earlier what we were doing exceedingly well in New York City. Vaccine numbers were going up and infections were steadily going down. Vaccine numbers flattened, and Delta variant became the dominant variant in the city. And while the vaccines are exceedingly effective at preventing illness and death among people who are infected, the Delta is so contagious that it's just generated a ton of infections among people who are unvaccinated, who continue to get sick, and sadly, even more sad, to die. And even among vaccinated people, a lot of infections, although generally very mild, asymptomatic, loss of smell, but nothing else, a little bit of sore throat. Several hospitals, including ours, have noted that all of the sick patients are unvaccinated. So vaccine, very good at preventing death. But meanwhile, we have more and more infections, and the more infections there are, the more risk there is of another variant, right? What causes a variant? A variant happens when the virus is replicating. Virus is not replicating, there's no variance. It doesn't come out of nowhere, it's evolutionary change. So best way to prevent that is to vaccinate people, because that's how you're going to eliminate the new infections. So healthcare workers, we feel, have a special responsibility. We take care of children who cannot be vaccinated. We take care of people who are immunosuppressed and who therefore may have gotten vaccinated but may have suboptimal responses to the vaccinated. And then we take care of a lot of people who, I think, through mostly misinformation, are frightened to get vaccinated. They tell you very explicitly their fears, which have been promulgated on places like Twitter and Facebook. They are, not true, but I've heard it from my patients as well as my staff. I'm worried about having this vaccine because I want to have children. There is no problem with getting the vaccine and reproducing. I'm concerned. I saw a poll that 1 in 5 people who don't want a vaccine believe that the vaccine contains a chip in it to identify them. And so there's this rampant misinformation, and while we're busy, doing everything we can to counteract it, we don't want people to get sick, right? We don't want to inadvertently, spread the virus. So the mayor has announced, and we are currently implementing, that starting on Monday, all our staff either have to be vaccinated or have to be tested weekly for COVID. Kenra Ford is our incident commander under Dr. Allen's supervision. I wanted someone who is phenomenal at operations and testing, and that is Kenra, because just so we're all aware, there will be bumps in this. Just for you to think, and Dr. Calamy and I were just discussing in the hallway, to do this means that we have 15,000 people in 70 different locations,
Yes.
working 3 different shifts on a 7-day schedule. We have to test all of those people and be able also to keep track of who's being tested so that the supervisors can tell them, right, that they can or cannot work. Now, again, we are doing this, in the most positive spirits, and we have gotten sign off from our unions, right? When I say most positive spirits, somebody arrives on Tuesday, they were supposed to get tested on Monday. Are we going to punish them? No. We're going to say, I'm sorry, but before you work, you have to go get tested, right? The whole idea is to keep the workspace safe. We're not looking to punish anybody. We're not looking to suspend anybody. We are looking to make the safest possible workplace. But there will be bumps, right? I'm sure there will be circumstances that I haven't yet imagined. A line of 100 people and not enough nurses, and so what will problem solve in the moment? And if that means we have to tell everyone, come back tomorrow. Today we're giving you a check on the computer system. Come back tomorrow for your test. We will do so. But I'm not aware that anyone has ever undertaken something like this, right? That's so heavily, right? Again, remember, 15,000 people is 15,000 labels, 15,000 swabs. All of the people required to do 15,000 swabs, all of the people being in the right place to get the swabs. And again, given the havoc of workplace schedules, there is movements across the country about vaccine mandates for healthcare workers. Our unions, as representatives of our workers, are very uncomfortable with mandates at this moment in time. They feel that our current poise allows workers to make a decision. But how things will, it's been a very brisk movement, and I think New York City deserves a lot of credit. We were the first to come out and say, you got to be vaccinated or testing, and then immediately following, we had California, similar decision, the VA, similar decision, state for the state hospitals. So, New York City, and I think this is right, that it would be a very progressive locality that needed to say this had to happen. It couldn't be a conservative locality. It would have to be a progressive locality to get over the fear that we were making people do things. And I think that the mayor's decision and announcement has had a huge impact. I think it's one of the largest impacts I've ever seen, where a decision one day changed what the world looked like 2 days later. There is a discussion going through, should it be mandated? The mayor himself has said that we're climbing a ladder. We want to start. One of my greatest hopes is that a large number of that 15,000 people get vaccinated. I think that would then, if that happens, that would show the power of this. I think if very few people get vaccinated of the 15,000, then it becomes a complicated question, because while testing is good, it's not as effective at preventing infections. Weekly testing still allows the possibility that somebody might come to work and inadvertently infect someone. And so, how we all as healthcare providers, we want to keep our patients safe. So, how this evolves, it will depend also on Delta variant itself. There have been some signs in England of it beginning to peak and go down. There's a lot of fear about winter, right? And, because of the cycles of, remember that last summer, while the city was closed, infection rates were also pretty low last summer, and then began to peak up starting in September. So again, this year will be better, I believe, because so many more people vaccinated. Nobody was vaccinated last fall. but the seasonal aspect will probably be the same. And so unless we have more people vaccinated, between now and the fall, we are likely to have increase of infections. And we don't, it was heartbreaking to see people die during the outbreak, but we all knew we did our best, right? We had no weapons to keep people from dying. Now it feels horrible in a different way. Every time I see a sick, unvaccinated person, I think we could have prevented this. Maybe not the infection, but at least we could have prevented this person from being on the respirator or a person from dying. It's amazing how well the vaccines work when you think about how new they are, and amazing how safe they are. I think Felicia is about to tell me that there's something I need to say. She wants to make sure that I don't forget to tell you that there are 2 contracts that we would have otherwise have brought to the board, but for time sensitivity. The first is a contract amendment with Rapid Reliable Testing for emergency COVID mobile units for testing and vaccination for a 9-month period with funding from the city's Office of OMB. RRT is the only laboratory in contract with New York City Health and Hospitals, which also operates a fleet of ambulances, and the only ambulance company in contract with us with laboratory capacity. RRT is uniquely qualified to administer overdose care, COVID vaccinations, and rapid on-site COVID testing, as well as to scale up capacity as needed. The contract amendment has a not to exceed value of $9 million. These emergency mobile units have been phenomenally successful, just phenomenally successful, way more than I ever imagined. So I think it's a good thing for us to do. And the second exemption is a contract amendment with Optum Insight Inc. to expand their emergency call center work to include calls to the public to encourage vaccination. The original agreement was limited to telephone work to identify the contacts of people who tested COVID positive and to encourage them to get tested and isolated. This was a repurposing of $18.5 million of allocated contract funding and involves no new costs. This is also funded through OMB. So with that, Madam Chair, thank you so much for chairing our meeting today.
Do we have any questions for?
I just have a quick question. Sorry that I'm prolonging this. But if the major order, if an employee from Happen Hospital is still telecommuting, will they have to be tested, or because they are telecommuted, they are only going to be tested if they come?
Wonderful question. We were handling this today. If you're permanent telecommuting, then you're not subject to this, because all we would do if you didn't get tested is tell you you couldn't come to work, and you're not coming to work anyway. However, there are people who are in hybrid situations. And if you're in a hybrid situation, you would need to get vaccinated or to test. I'll also mention, because you may hear complaints about this. In a hospital, occupational health is always defined as the hospital. So you might be a finance person in the basement, and you might resent that you are being required to get a vaccine or to be tested. You might say, this doesn't make any sense. I am not taking care of patients. But you are walking into that hospital, you are walking past the waiting rooms, you are in the elevators, and we believe that all of us are, in fact, in an emergency, healthcare workers, right? And I like to give the example, at the peak of the pandemic, my secretary, Devika, bravely went to work at Queens Hospital along with the morgue, because that's where we needed her, right? So she was a central office person, right, who could have said, well, I don't see patients here, right? But she went because we said, we need you there tomorrow. Will you do it? And she said, yes, I'll do it, because that's what's needed. So we for this work, if you come to work, if you are not telecommuter, if you come to work at 125 or at Water Street or at any of our administrative places, you are subject to it because we believe in an emergency. We are going to ask you, and we cannot define when that emergency happens. And again, that is the traditional way. That's what we do for measles, mumps, and rubella. That's what we do in terms of physical exams, right? You work in the hospital, you're subject to those rules.
Have we considered vaccinating whole families?
We definitely, we have vaccine appointments by families. We've done like social groups. We allow people to like bring their church group. We'll do like 20 appointments. Yeah. I mean, I think, you know, the city, another thing, the city, $100 now to get, if you get vaccinated. I mean, the city, I think people are really trying to do everything right. But sometimes, and you know, again, I think the history is interesting. Smallpox was not eradicated on the idea of a voluntary vaccination. And smallpox, some of us in this room are old enough to have had it, was not a simple vaccination, right? Those of us who have the scar, right, that vaccinia caused disease and even in rare cases death. And still everybody lined up and got their smallpox vaccine because that's how you eradicate horrible diseases. And because of that, there's no smallpox. And young people, our children, are not vaccinated because our generation, eliminated it. And so our children do not have to get vaccinated. And so that is how, in the history of public health, you eradicate diseases. And so, but this is not that moment. Right. And all of us, I think, believe, do everything to help people make the decision to save their own life, to save their family's life, to not bring home an illness. It may be that some people need a little bit more of a push, and that's to be determined. You'll never achieve, in modern day, 100%, unlike the smallpox. And there are people who have true anaphylaxis due to vaccine. They're very small, but there are such people. So we acknowledge that, and those people have to have other kinds of provisions. But I think ultimately vaccination will be necessary in the US, but not now.
Mitch, this is, I know I'm moving beyond, but there has been discussion of the vaccines losing effectiveness. Is that a concern?
So it has not yet. You know that this is happened, right? So our usual thing, well, historically, there's no historical, right? Vaccine levels in almost all diseases wane over time, what you measure. However, that doesn't mean that people can still get sick just because your antibody levels go down. So that's what's mostly being measured now. When you read studies, they're measuring what happens to the antibody levels. Same with a fascinating issue that we'll someday know the answer to. Pfizer was pushing for a booster shot based on science showing that antibody levels increase with the booster. But that's not proof that you're going to be less likely to get sick. Right. So depending on who you are, you either think, gee, I saw that data, we should all get a booster, or you think this is another example of Big Pharma trying to make money by pushing a product that we don't need because the two vaccines are working. In 6 months, in a year, in 2 years, I think one instructive thing, still very few breakthrough cases. Still very few people who got sick with COVID, who are getting sick a second time. It happens, but very low numbers.
You don't mean getting infected, you mean actually getting sick.
Yes, it's in general, the people who got sick mounted much stronger immune responses, as you'd expect.
Right.
And for many of the people who just got infected, they're hard to know about anyway, because many of them never got tested. But among people who were sick with COVID, which now allows us to go back much further in time, right? Because that's more than a year, right? We're now about a year and 4 months from the peak in New York City. We're not seeing very many reinfections. And so that suggests that that immunity is lasting, and immunity can last even if the antibodies wane, because our bodies are so smart that they have multiple ways of defending themselves, and there are memory cells that when they see the antigen automatically start making more antibody. So it remains very open, but at least at this moment, all of the data say that if you're vaccinated, you're not going to get sick and die. That's what allows us to return to our old world.
Just on your point, because I think the data, you're right, is being very supportive of very few breakthrough on previous COVID infection. Do we look at the number of employees? That has been an issue, I think, with some hesitancy, is the idea that there's going to be worse side effects if you get a vaccine after you've been infected. And yet I feel a little bit more comfortable knowing a significant percentage of those people may have had COVID. I'm just curious, do we have any knowledge of that?
We know, Vince, that a lot of people did have COVID. So we do think that a fair number of the unvaccinated people. The problem is there's no single accepted antibody test. There is concern, although no proof, that the immunity provided by natural infection might not be as strong for variants. Although again, that goes against this idea, well, if that's the truth, then wouldn't we expect to see by now natural infection occurred a year ago at the peak? Shouldn't there be a lot of people now coming down sick with Delta? And the answer seems no. But the vaccine is clearly safe for people who've been previously infected. They may have a little bit more, basically, they have the manifestations of additional immunity, right? I mean, in some ways, it's not even a side effect, it's the main show, right? They're having a reaction because they have a lot of immunity now, and that should be a good thing. So yes, at times it was discussed, and it was just felt that adding in, proof of immunity, given the variety of tests, the variety of circumstances, just wasn't going to achieve the goal.
Well, thank you.
Thank you.
On a related matter, at the bottom of the capital committee report, it says the 50 Water Street office consolidation project was wrapping up, and the next board meeting will be held in new location in September. So it's like we make a capital committee meeting at a doctor's appointment. Is that the case, that in September we'll be downtown?
Yes, and it's beautiful.
Further downtown.
It's beautiful and it's more spacious. Felicia, anything else you want to tell people?
The view.
The view is amazing. We have a bigger conference room. The capacity here, I think we're going to 150. With the larger conference room on the 15th floor, that would seat up to about 300. So the space and the capacity and the technology will be amazing.
So I need to be prepared 10 minutes early.
The commute.
And committee relations also meeting in September downtown.
Yes.
Okay.
We will do.
I have to mentally prepare myself.
Okay.
Thank you. Thank you very much.
The commute, you're worried about the commute.
Great. All right. Are we, so the committee and subsidiary reports were emailed to you, and Bob has just looked at them, and they're in your
Has read them.
their submission into the record. Are there any questions or comments other than Bob's? So any old business or new business? Then if there's no further business, I declare us adjourned and wish everyone a good summer and see you in the new building.
Well done.
1 month.
Well done.
You're a product company.
Now, at least we know.
I think too. Not that you needed it for any.
Yeah, it's like mushy muscle, so I'm gonna build
So
up
Mitch,
again.
it is true.
But I'm gonna give it germ tolerance.